Good afternoon. Thank you for joining us. I'm Elizabeth Poole. I'm the director at Langston Brown 55 Plus Center. And we are here today to talk about Continuum of Care. And we are going to turn this over to Elena Nelson, who is with Arlington Neighborhood Villages. She will introduce our panel today. And we are recording this program, and we would like for you to use the chat. So welcome everyone, and Elena, I'm turning it over to you. Thank you, everyone.
Thank you very much for all the participants and for all the presenters that are here in the meeting. And I'm very happy after 4 months or 5 months, we have again Continuum of Care. I want you to know that we are doing this presentation with the same institutions for more than 4 years now. So we are taking this Continuum of Care is basically information for our constituents to know the services that are offered and how to access the services and how much it might cost, or if it is possible to be accessed with the insurance. So this will be the structure for each presenter. And we'll start with the Arlington Neighborhood Village. We'll continue with Mitch Opalski, that is the CEO of the Synergy Homecare for the services offered by the Homecare when the Arlington Neighborhood Village is not enough anymore. And we continue with Deb Klein, that is the Executive Director of the Jefferson. And after that with Shannon, that is from Goodwin, Living at Home. And finally, we'll have Jessica Ford, that is the Director of the Client Relationship at the Capital Care, that is a hospice basically. So I thank you very much again for your participation. Each presentation will be based on the PowerPoint presentation. After all the presentations are done, we'll have a session of Q&A, questions and answers, and that will not be recorded, so you can go as personal as you want. And if you have burning questions during the presentation, as Elizabeth said, I would like you to put in the chat so we don't interrupt the presentations and we give a chance to each presenter to say everything they want. Thank you very much. Please, Jean.
Thank you, Elena, for that nice introduction. My name is Jean Rade. I'm the Member Services Manager here with Arlington Neighborhood Village, and I'm delighted to be a part of the Continuum of Care. Arlington Neighborhood Village is a nonprofit organization here in Arlington, and our mission is to support senior citizens, those Arlington residents who are a little bit older and who may need a little bit of help in order to live as safely and independently as possible as they can in their own homes. And I'm going to load now, I hope, my presentation. I'm going to share my screen with you. Yes, Arlington Neighborhood Village is a nonprofit here in Arlington, and we support senior citizens in helping them to be as safe and independent as possible, but yet staying connected to their family, friends, and their neighbors. And it really gives a lot of peace of mind to folks, especially when family members are far away and they find themselves possibly increasingly alone here in Arlington as people move out of town. Maybe longstanding friends and neighbors may even pass away, and leaving a person feeling quite isolated. An older person may give up their car for some reason and suddenly need help with transportation. They may have a time-limited, perhaps, injury or illness, which makes it difficult to get out to get their own groceries, go to the post office, go pick up a prescription, and they may need help with those errands to get those tasks taken care of. So we can provide the kind of tasks that a person may normally ask a family member for, or a close neighbor or a close friend, but they could ask us to take care of those tasks. And sometimes that's really nice because it frees up the friend, the neighbor, the family member to take care of things that we might not be able to do. We're really a community of volunteers. We are definitely volunteer driven. We have over 300 volunteers who are actively engaged with our organization, doing things ranging from providing those rides, taking care of those errands, all the way over to serving behind the scenes on committees or on our board. The middle button there, or the middle button, shows the types of services that we offer, the errands and the transportation, as I mentioned. We also do home chores and home maintenance. These are generally light tasks around the house. It could be changing a light bulb, installing a curtain rod. It could be if a person is getting ready to move or just wants to downsize a little bit and stay where they are. They may need help going through their items, sorting through things, possibly packing them up, maybe even taking them over to a donation center. And our volunteers can provide those sorts of tasks around the house as a home chore. The distinction with the home maintenance is that the maintenance tasks tend to involve tools. So that could be something, again, the curtain rod, installing a curtain rod may involve tools. Let's see, daily check-in. A daily check-in is a service that really gives people a lot of peace of mind when you're living alone and you just want that assurance that somebody is going to check in with you during the day and then activate your emergency action plan if contact can't be made. So we do that contact Monday through Friday, either by email or by phone. And it can go either way, that we would initiate the contact or the member would contact us, either by email or by phone, just a very brief 5-minute little check-in. How are you doing? Do you need anything right now? Kind of conversation. That's the daily check-in service. You'll see in that same button there, we also offer tech support. Most people seem to need tech support for their computer devices or for their phones. We can also support televisions, thermostats, and other things that operate through technology in the home. And especially during COVID, the early days of COVID, we tried to provide those services as much as possible over the phone, troubleshooting issues over the phone and guiding the member on what they could do to resolve the problem. And if that wasn't successful, we then do go into somebody's home, into a member's home, to offer further tech support. It could be a one-time troubleshooting an issue, say a computer doesn't start or a screen is frozen, all the way down over to multiple visits into the home to provide ongoing education on how to use a particular app or how to use a particular service on their technology. So that's tech support. Our walking and conversation partners are fantastic. This is that one-on-one engagement directly of a member with a volunteer on an ongoing basis. So the walking buddies and the conversation partners or phone visitors, that's an ongoing service of about an hour or an hour and a half once a week between the same member and the same volunteer. So a really nice relationship can develop over time through those partnerships. And when members request a walking buddy or conversation partner, they tend to be very specific, which is really helpful to let us know what type of person with what types of interests that they're looking for, because those partnerships can involve ongoing conversations on a particular topic of great specific mutual interest. And they could also be home visiting partnerships. Again, it's once a week or so for an hour and a half at a time. And it could be as simple as a conversation, or it could be working on a hobby together, a shared interest, shared hobby, or it could be a combination. It could start off with a conversation, and then the two may decide to go out for a walk. If one or the other is not well, it could turn into a visit by phone during a particular week. So there's a lot of flexibility and fluidity on that. But the idea is to have an ongoing relationship with another person for the foreseeable future. And some of those relationships have been going on for 3-4 years, practically since we were founded. The third button there, you'll see the social and the community. These are activities that we do for fun, social activities. We have bocce once a week in the Ballston area, which has actually evolved now to bocce and the game of boule. So a person could play either one. We have Tai Chi once a week in the Virginia Square neighborhood. And that Tai Chi is a practice. It's not an instructional session. It's a practice session. We also have group walks 4 times a year. These are seasonal walks that are held on Roosevelt Island, led by one of our longstanding volunteers. We also have a book group called Page Turners. And this is a really interesting book group. It's not a traditional book group where everybody reads the same book. In our Page Turners group, each person brings to the session whatever they're currently reading and shares about whatever it is they're currently reading. Our garden group is on hiatus right now, but that's, as it sounds like, a group that discusses gardening. Coffee and Conversation, this takes place once a week, every Wednesday morning from 10 to 11 on a different topic each week, but it's a series of presentations of interest to our particular group. And those are currently going on over Zoom. It used to be in person and it may go back to in person at some point, but right now it's strictly over Zoom. The Zoom link is on our website, and that's actually an activity that's open to anybody in the community. It's not limited to members and volunteers. So if you may be interested in getting to know us a little bit, but not quite ready to think about joining as a member or a volunteer, we hope that you'll click that link on our website and join our Coffee and Conversation. We also have tours periodically. We had one recently to the Mormon Temple, and we may have another one coming up, and our members know to look for our tours in our activities and events bulletin, which comes out twice a month. And finally on that list, there are our holiday potlucks. Those are a favorite of our members. We have a potluck traditionally for Thanksgiving and another one in December. You don't need to bring any food. You could just bring yourself, as they say. You know, yourself is a present. And a great opportunity to share the joy of the season and camaraderie with each other at our potlucks. And those are always held right here in Arlington in person, of course. Let's see, here you'll see in the next slide some pictures of actual members and volunteers. On the left, the woman with her pet is very typical of our membership. Most of our members are actually women. And although membership begins at age 55, most of our members are 70 or older. The next picture going clockwise here, this is one of our volunteers there in the striped top leading a course called SAIL, which stands for Staying Active and Independent for Life. So this is a class led by one of our volunteers, again, a fitness program available to our membership. The next picture, you'll see a volunteer accompanying one of our members home after having taken the member shopping. So you'll see here that the volunteer doesn't just drop you off on the sidewalk. If you'd like assistance bringing your groceries in and even putting them away in your kitchen, our volunteers can do that as well. Down below, we have a member enjoying a potluck activity event. And the next picture is a home visit between a member and a volunteer. So as I've mentioned, most of our membership is comprised of women. Our members live throughout the county. There used to be a sense that our membership is only available to a certain part of Arlington, but that's not true. We are available to anybody who lives in Arlington who is at least 55 years old. We have a lot of diversity in our community, both with members and with volunteers. A lot of different experiences, interests, and needs among our membership. And one of the items I know that I'm to address in my presentation is the membership fee and how to access that. So as an organization with overhead costs of our office and other things, we do have a membership fee. The standard fee for 1 year is $500. That's for an individual. And the price is $750 for what we call a household. That's 2 members. And if there happen to be 3 people in one household, all of whom would like to join with a membership, it's an additional $250 for each additional person in the household. We do have discounted fees available, and I'll present those in another slide. Our application process can happen in as quickly as...
Sorry, Jean, sorry to bother you, but you already passed the 15 minutes.
Okay, all right, I'll wrap it up. The application process is very quick. It could happen in as quickly as a week, or it could take much longer, depending if the pace is really set by the member, the applicant themselves. But it does consist of forms, a home visit, and the payment. Here you are, our discounted fee structure. is available to individuals whose income is below $47,250. So if that's an individual, the income cutoff is $47,250. And if your income falls below that level, the annual fee would range between $100 and $25 per year, depending on the income. And the numbers are a little bit different if you're a household. You'll see in the chart below there. If the combined income is below $50,400, then you'd be eligible as a two-person household for the discounted membership, which would range from $150 down to $37 for the year. And you'll see my last slide down here has my contact information. If you'd like further information, please don't hesitate to reach out. We'd love to be in touch with you. And thank you for your attention.
Thank you very much, Jean. Mr. Michopalski, please. Yes.
Yes, good afternoon, everybody. I also want to screen share, so let me do that. And there we go. Everybody can see, Elena, that's showing up?
Yes, perfect.
Great. Well, first I want to say welcome to our presentation, and we've been doing it 4 years. I'm the owner of Synergy Home Care right here in Arlington, homegrown. We've been around for 15 years. We are a preferred provider for your village, Arlington Neighborhood Village. But I want to commend you all for being on here today because you're doing your homework, so to speak. You're finding out what resources are available in the community, either for yourself or your loved ones or friends or neighbors. And that's important to know because, you know, our people complain about our healthcare system. It's so disjointed. There are a lot of different providers, and if you don't know what's out there, you might miss out on some important help. So let's dive in. I want to really keep this high level today. I could talk, of course, to you all day about home care. It's my passion, but I'm going to stick to answering 3 questions, and you can contact me later or ask questions at the end to dive in deeper. I want you to have a thorough understanding of what is home care. What does it mean? And what are the types of services offered? Number 2, if you think you need it or qualify or whatever, how do you access it? How do you start the services? And the 3rd question is all important, right? Who's paying for this and how much does it cost? So let's dive in. First of all, it's important to know that there are 2 types of home care services brought into the home, commonly referred to as a skilled or medical. And then for the other side, we just throw the non on there, non-medical or non-skilled. Let me just focus on the right side for a minute, the skilled care. This is not the kind of care that our agency provides, but it's available. And it's when a nurse, an actual nurse or a skilled person, such as a physical therapist or any of those on the list there, would come into your home on a doctor's order for a period of time to provide these services. On the other side of the coin, we have non-medical. These are certified nursing assistants or home health aides. There are unfortunately several different names for our employees, personal care attendant, just to confuse you even further. But these are the 3 levels of care that our agencies provide on the non-medical side: personal care, homemaker care, companion care. So let's dive just a little bit down to the next level on what is personal care. And it is the assistance with activities of daily living, all these things that we do every day. And as we get older or incapacitated, we may need help with them. The homemaker chores are very much needed in the home as we age in place. And it includes everything from light housekeeping to laundry to running errands. And lastly, companion care, which does include memory care, is really all about safety and supervision, social engagement. Jean mentioned social isolation, which was, of course, during the pandemic was a big problem. Transportation, reminders, and really just coming and checking in on folks. Okay, so I'm not going to walk you through every slide. I have some extras here, and I hope that they'll be available to you later via email because I want to answer those 3 basic questions. So I'm going to skip this one. Now, let's talk about how do you access home care and how does it work? Well, we do offer service 24/7. And one of the great things about home care is it's very flexible. You set up the schedule, the number of visits. Often agencies will have some parameters like a 4-hour minimum per visit or a certain number of hours per week that you have to sign up for. But basically you're setting a schedule when your CNA or home health aide will be coming into the home to provide those services that I listed. There's also live-in care available where one caregiver stays in your home day after day after day. And there are particular arrangements that have to be in place for that, like a separate bedroom for them to sleep and so on and so forth. So how would you find a home care agency to work with if you think you need it, or your loved one or family member thinks you need it, or your doctor? First of all, you need to obtain a list of agencies. Now, in today's internet world, that's pretty easy to do. You can Google Home Care Agencies Arlington. I don't know if you can see in the little screen because of the presentation, but there's a book called the Source Book here I'm holding up, which is published 3 times a year. So those of you that still like magazine type paper format, you can get a hold of those at the local library, or you can call proaging.com and have one sent to your home. And it's a list of all the providers by county, by type of service, and all the home care agencies are in there. You should also ask around. Word of mouth referrals are important because it's usually someone that's used the service or the agency, and they can opine on the quality. So once you have your list, you need to narrow it down because you're probably going to treat this like, honestly, finding a plumber or a roofer. You're going to call and inquire and get some information on the phone, pricing. You're going to get a feel for that agency and the other person on the line. Is it someone you might want to work with? We have a document called the 14 Most Important Questions to Ask here it is, your home care agency when you're doing those phone screens. And then when you narrow down to the 1 or 2 you like the most, then you should call them into your home for an in-home consultation, which is usually done free of charge. So this sounds like a long process. You can shortcut it by, like I said, by getting a referral or a recommendation from somebody that already can attest. Now, if you're an Arlington Neighborhood Village member, our agency has been vetted by your village. So I would dare say you might not have to go through all of this. You could just call us. Okay, let's talk about who pays, right? We all care about this. We have insurance, we have Medicare. I don't have good news for you here. On the non-medical care side, it's not a benefit that's part of our Blue Cross Blue Shield or Cigna policies because it's not skilled. It doesn't involve doctors, nurses, drugs, hospitals, outpatient, centers. It's a home health aide coming into your home. So, but on the medical side, just going back to the skilled care in this slide, the top part, if you're having the nurse come in or the physical therapist, that is paid for by health insurance or Medicare. So if back to non-medical, if an insurance company is not paying, well, who are the payors? Well, unfortunately, 80% of people end up paying out of pocket because they don't have a long-term care insurance policy, which is a separate kind of insurance designed specifically for this type of care, or they don't qualify income-wise. You have to be quite destitute to get home care services paid for by Medicaid. In other words, you have to kind of spend down all of your assets and have very little income. Good news is if you're a veteran, they have 2 programs that pay for home care. And it's gotten a lot easier to qualify and get that started through the Veterans Affairs. And then something to look into too, life insurance companies are getting creative and they're allowing you to convert your life insurance policy to start paying for home care services while you're still alive, which is pretty nifty. You'll have to inquire to your own insurance company. Okay, so most importantly, if I'm paying out of pocket, how much is it? So to have these services in your home on an hourly basis here in Northern Virginia, the range right now is $28 to $32 an hour for the personal care, the highest level of care. You might get away with a lesser hourly charge if it's only companion care because it's easier work for the aide. The live-in caregivers that I mentioned would run between $300 and $400 a day. The ranges on these services, I want to point out, are pretty wide right now because everybody's all the agencies are trying to adjust to workforce shortages and recruiting new caregivers and retaining them, which is driving up wages. And of course, it has to be passed on to the consumer. Rates can be negotiable depending on how difficult the job is for the aide. I wanted to mention real briefly on COVID-19 because my employees are coming into your home. You want to know what the status is. Well, all of our caregivers are vaccinated and we don't do regular testing. We trust our caregivers to self-assess for any illness. As of these days, any symptom whatsoever, a sneeze, a cough, you're staying home, we'll test them or they test themselves with the home kit, and we keep them off work enough days to know for sure they don't have the COVID, and they're paid to stay at home until we pass those CDC quarantine periods. Of course, we've heightened our infection control, and we'll do the testing only with symptoms or if they've been exposed to somebody, so that we can be safe for our clients. So I want to end there and respect my time, and we will move on to the next speaker. I look forward to any questions you have at the end, or a phone call or email directly anytime after the presentation. Thank you very much for your attention.
Deborah, please. Thank you very much, Mitch. Yes.
My name is Deb Klein. I'm the Associate Executive Director at the Jefferson, and it is my pleasure to discuss facility-based care with you. So there are different types of senior living facilities. The Jefferson is only one model, but we do have independent living, assisted living, memory care, and skilled nursing services, and I'm going to touch briefly on all four of those. So independent living, what we would often describe as a retirement community or a 55-plus community, has so many different variations that it's really hard to say a lot that applies across the board to all of them. In general, folks who are looking to go to this type of a community may be either looking for more socialization because the friends that they used to have in the neighborhood have moved away, that maybe they don't drive anymore, and so access is an issue. Or the other thing is not taking care of such a large home. When home chores, that was something Jean mentioned, that's a popular request for volunteers, is help with home maintenance chores, and that can become too much for people, so wanting to downsize to something that's a little bit more manageable where a lot of that maintenance is covered for you. Aside from that, it's very hard to speak in general about independent living facilities. We often joke that when you've seen one, you've seen one, because there's such a wide variety of services and amenities that are available. There's a difference in financial structures that are available. But in general, one thing they do all have in common is that these are consumer purchases. They are not things that require any kind of a medical referral. In many cases, they don't require a medical assessment. In some, they do. But there's a huge variety. So I would say if this is the type of living situation that you are interested in, go and see as many different possibilities as you can, and you will see the variety, and it will definitely guide your decision. Moving to assisted living, there is a lot more comparability and similar structure in these type of communities. Assisted living is often a service that's offered in combination with independent living or skilled nursing, but it can also be a standalone. And it is a social model of care. So this is intended to balance providing supportive needs with privacy and independence. It is not generally considered heavy medical care. So the type of services available: meals, social activities, some light medical services like medication administration and nursing oversight. But we're not talking about having every service administered by a licensed nurse. In recent years, we've seen an increase in assisted living being used for short-term stays, such as transitioning after a hospital stay before somebody returns home. But it has and can still be a long-term service that is used for several years. What triggers assisted living is often something like a fall or a change in condition that might be sudden, or a need for more assistance for something that is not predictable. So, for example, if you need a little assistance getting dressed in the morning and undressed in the evening, you might use Mitch's services and bring in a home care aide. But when it gets to the point where you need assistance every time you go to the bathroom, then it becomes a round-the-clock need. And if that's not something you want, to have an aide in your home round-the-clock, just for when you have to go to the bathroom, then you may want to go to a place where those services are available, but you're sharing the cost of that service and the use of the person providing the service with other folks there in the facility. Like the home care services, assisted living services are generally not covered by health insurance. So this would be similar to the non-medical home care services that Mitch described, where you have private pay, long-term care insurance, veterans benefits, and then, of course, there are some tax-deductible advantages to that as well. Unlike most independent living, there is a medical component to assisted living. You must have a physician who can give orders for medications and things like that when you're in assisted living. And there is paperwork that must be completed by the physician as part of the admission, but you don't have to have a referral. You can still shop for assisted living as a consumer product, just like you can with independent living. It's just that your doctor is probably going to be involved as part of that move. Mentioned some of these things already. You know, meals and activities are a big emphasis in assisted living. The type of care that's provided, again, is similar to the non-medical care that Mitch described. So those activities of daily living. But again, you are sharing the caregiver with other people. So they're not sitting there in the room with you the whole time. They're generally going to stop in periodically to check on you, or you'll have some sort of a calling device to signal them when you need some assistance. Assisted livings usually also staff some nurses. They have medication aides, registered medication aides, or LPNs, who may provide medications and some limited types of dressing changes and other types of nursing services. And then there's an RN who usually oversees the program. And then most of the medical care would be coordinated with outside providers. So you might have physicians who you either go out to see or who come on site. You could have things like podiatrists, psychiatrists, other specialists that come into the building, and then maybe also a physical therapist. Hospice services are another service that's commonly brought in and coordinated with assisted living services, and we'll hear a little bit more about that later in the presentation. By comparison, nursing care or skilled nursing care or nursing home would line up more with what Mitch described as the medical home care services. So these are facilities that are staffed 24 hours a day by nurses. They have a medical director that provides medical oversight. They usually also offer some rehabilitative services and therapies as well. These types of services have been becoming more and more short-term as well. Pandemic has certainly hastened that. Folks don't seem to go into a nursing home for long-term care as often as they used to. Now we see a lot more short-term care. This is considered kind of the step down from the hospital when someone's not quite medically stable enough to go home. After an extended illness, after an injury, after a surgery, if you can imagine a surgery with a dressing that needs to be changed frequently, a wound that may not be healing properly, those are the types of situations that we're seeing. There's good news on the payment front here. Medical insurance does cover some or all the costs of the stay. Medicare Part A covers up to 100 days, and I say up to because you need to continue to meet Medicare's criteria to qualify, and if you do not, then the coverage stops. So if you meet the criteria up until day 45, you have 45 days, not 100 days. There is a copay starting at day 21, but the first 20 days are covered 100%. And then folks often have a secondary or supplemental insurance that will cover some or all of that copay for a period of time as well. So if you have Medicare and you have a secondary health insurance, the coverage for this type of service is usually pretty good. For this, you do require a referral for a short-term skilled nursing stay, and usually that is for somebody who's transitioning from the hospital, so that admission is usually coordinated between the social worker or discharge planner in the hospital and someone on the nursing home side that's receiving the patient. So there is a physician's order, clinical records are sent by the hospital, and everyone needs to sign off and make sure that the type of care that's needed can be provided in the facility before you're admitted. On the flip side of that is what would be considered more long-term care. And so this, again, is more akin to that non-medical service that Mitch described, and it can take place in the same facility. So you still have nurses 24 hours a day, but the nurses may not be the one providing all the care in this case. If someone's coming from the hospital after a surgery and they have those medical needs, they're here under their health insurance, they're receiving medical services. If someone has been living in the nursing home for 2 years and they're pretty stable, they may not need those medical services anymore as much as they need those activities of daily living like you might get through home care or in assisted living. So when we talk about a long-term care stay in nursing homes, we're talking about a stay that's usually more than 100 days, and that 100 days comes from that wonderful Medicare benefit. There can still be some medical needs, but it can just exceed what the health insurance covers. So somebody who has a chronic wound that isn't healing, or who has tubes for feeding and hydration, somebody who has respiratory difficulties that require a ventilator or some advanced respiratory services, those are needs that are going to be more long-term and don't need to be provided in a hospital, but are not as commonly provided in a home care setting, and in Virginia are prohibited from being provided in assisted living setting. That means that when you get past that 100-day mark, even if there are medical needs, the room and board portion, at least, of the nursing home care is usually not covered by health insurance. That's for short-term coverage. So again, you're back to the private payer, the long-term care insurance, the veterans benefits, and here in a nursing home setting, also Medicaid for those of a lower income bracket. Admission for long-term care can be coming from any other setting. It can be from a short-term nursing home. It can be from assisted living, but it does also require a physician's order for admission. And again, all that paperwork has to be reviewed to make sure the needs can be met, and everybody has to sign off on that. Again, I kind of touched on these services that are offered in nursing care, regardless of whether it's short or long-term care. You're going to have the 24-hour nursing coverage. You're going to have some therapies. There's usually a dietitian on staff. There's a program of activities, social services, and discharge planning. Facilities usually contract and bring in diagnostic services like the lab, x-ray, ultrasound, things like that, and then coordinate care with physicians and other specialists. But in most cases in a nursing home, those specialists do come in on site, or the nursing home takes care of coordinating trips to and from those offices if needed. And then I want to touch briefly on memory care. Memory care can be offered either as assisted living or as nursing care, just depending on how the facility where it is done is licensed. So for example, at the Jefferson, our memory care is licensed under assisted living, and the real difference between memory care and those other services is simply the social aspect of it and the safety aspects of it. So in a dedicated memory care area, you may have programming that is structured to be more accessible and easier for those with memory impairment to use. You will also likely have locked doors and other security precautions to keep someone with a memory impairment from wandering away and getting into an unsafe situation. It can be done as a long-term or short-term stay. Also, you hear the term respite stay, which is usually a short-term stay when perhaps a caregiver is not available or just needs a break. And memory impairment can be managed in a lot of different settings, but folks generally start to turn to a facility-based care for memory care when the memory impairment is so severe that the person really can't be left alone even for short periods of time unsupervised. If they might wander off and get lost, or if they might, for example, turn the stove on to cook and start a fire. When those kind of impairments become a safety issue, that's usually when folks start looking at a memory care facility, because there is staff 24 hours and there are multiple people who can help with the supervision. It's not reliant on one caregiver who can't even take a quick break without having to worry about leaving that person alone. Lastly, because I do want to respect my time, I just want to touch briefly on the COVID-19 response, because I'm sure you've all seen and heard many things about nursing homes and the number of COVID cases and deaths in nursing homes and retirement facilities. And it's really a shame that there has been so much negative coverage without the balancing positive coverage, because there are a lot of facilities that had very different experiences. We're one of them, and that really had a lot of good infection control practices in place to protect their residents. So just to tell you a little bit quickly about the kind of things that we've done, Jefferson and actually all of Sunrise Senior Living, our parent company, has mandated 100% vaccination for all of our employees, and that includes the booster shots. So the second booster shot has not been mandated for everyone yet. If it is, we will be requiring that. At this point, the first booster shot was mandated for everyone. And if the second one becomes available to those of us below 50 years of age, then that will be likely required as well. We've also assisted our residents in getting their vaccines, and at this point, 95% or more of our residents have been fully vaccinated, and we've got a booster clinic coming up in 2 weeks, actually. We do those clinics through a combination of sources. We've worked with CVS, we've worked with Preston's Pharmacy here in Arlington, and also the Arlington County Public Health Department. They've been terrific in helping us make sure that our folks have access to vaccines when and where and how they're able to receive them. We are still requiring masking in our common areas. We ask people if they're walking down the hall or riding on an elevator to have that mask on. They can choose to take it off when they're in their private apartment, but all staff are required to wear masks when they're around any residents, and we do recommend it for everyone else. One of the other common misconceptions has been that if someone moves into a nursing home or assisted living, you won't be able to see them if there's any COVID, and that is also not true. Early on, there were some tight restrictions on visitation. A lot of that was before the vaccines were available and before a lot was known about the virus that we know now. So actually, we are prohibited now from restricting visitation unless the Public Health Department explicitly tells us we need to do so. We do make some recommendations, like visiting outside if possible for air circulation and not visiting when you're sick. We require full protective equipment if you are visiting someone who is COVID positive. And we do make adjustments as appropriate to how we offer things like communal dining and group activities based on what we're seeing in the population with COVID cases. But again, I want to emphasize that if somebody moves into a nursing home or an assisted living today, they are not isolated. They are not prevented from having visitors. Visitors are not prevented from coming.
Thank you very much.
I'm going to pass it on to the next speaker. There's my contact information, and I would be happy to share these slides and answer any additional questions.
Thank you, Deborah. Shannon, please.
Sure.
Yes, please.
Can everyone see my screen? And it just says Goodwin Living at Home, I hope.
Yes.
Okay. So good afternoon, everyone. My name is Shannon Bishop. I am one of the senior sales consultants with Goodwin Living at Home, and we are part of what used to be called Goodwin House. Goodwin House is an organization in May, changed its name to Goodwin Living. What we found is that over the years, and as we've grown, we serve about 1,000 residents within the 2 Goodwin House communities. And we are serving amongst Goodwin Living at Home, our home health and hospice, and participation in a PACE program, roughly 1,000 people outside of the 4 walls of the Goodwin House communities. And then on August 1st, we intend to complete an acquisition of our neighbor, the Hermitage of Northern Virginia. So we are indeed growing. So Goodwin Living at Home is what's called a continuing care at home program. Today, we are an option for independent, healthy, older adults who are 55 and older and wish to plan to age well in the home of their choice. It's an alternative for those who do not wish to move to a continuing care retirement community like one of our Goodwin House communities, but is an option if in the future someone does move to a community we do pay. In the present, we want to make sure that our members are safe, happy, and healthy with the spiritual wellness they need at home. And continuing care at home meets kind of 3 key aspects. We provide access to quality care by a network of providers that we have vetted and feel comfortable and confident that they will provide the best support to our members wherever they live. Care coordination and advocacy through our staff called Facilitators. These are social workers who have a background in senior and aging services, both in a healthcare setting and in private organizations. And these facilitators are on call to our members and their families 24 hours a day, 7 days a week. They can be your advocate if you're in the hospital or you're coming out of a hospitalization, but they're also a resource for you. So if you need a plumber, if you need a new physician, unfortunately, we have a lot of members whose doctors have either retired or unfortunately, a few of them have passed away. So we will provide a resource to do medical care if a member needs. And then Goodwin Living at Home is designed to provide financial protection against the higher costs of care. Currently, we have 210 members in Northern Virginia and Washington, D.C. We started in 2014 and are the only continuing care at home program in Northern Virginia and Washington, D.C. There is a continuing care at home starting in the Baltimore area, and there are 2 in Southern Virginia. The facilitators, as I mentioned, they're the guides throughout your life. And as no one would go into a courthouse, or most of us wouldn't go into a courthouse without a legal advocate, this is your medical and lifetime advocate. They speak the language of healthcare and are available for you and for your family. For members, they also coordinate entry into the Goodwin House communities if members want to use the pool, the fitness center, and use the social supports the 2 communities provide. And there's a team of 6 of them. All members have a facilitator, but you can end up speaking to any of the 6. The way we protect against the cost of care, and Mitch, thank you for sharing some of what those costs of care are today, is that when a member joins, they choose plans that determine how much per day Goodwin Living at Home is going to pay on their behalf for care. And that care is either in someone's home, in an assisted living community, or in nursing care. What we will pay over the lifetime of a member. No matter how long a member lives, the total dollar value we will pay out on their behalf. And care at home could be in your home where you live today. If a member is a member for a year or more, and they end up moving out of Washington, D.C. metro area, their benefits will transition with them wherever they are. And there is also an international benefit if someone is out of the country and needs assistance, their benefits will pay. The way that the financial options are set up is that there is a one-time, it's called here an entrance fee, but it's also referred to as a membership fee. That membership fee is based on the plan that you choose, how much coverage you want us to pay out on your behalf, and age. The monthly fee corresponds to the particular plan, of which there are 5. And then your benefits will pay out each year for you, and there is an adjustment for inflation each year. So for example, every November 1st, the benefits increase. There are 5 financial plans. I've highlighted 4 here. Our most comprehensive plan is called the Colonnade. We, Goodwin Living at Home, will pay 100% of your daily cost of care, up to $448 a day. And again, that's in your home where you are now, in the future, in assisted living or nursing care. We have a plan that's called the Pillar. The Pillar is where we will pay 75% of your daily cost of care, up to $336 a day. The Canopy plan is a third option where we will pay half of your daily cost of care, up to $223 a day. Under the Pillar plan and the Canopy plan, the member, or if they have long-term care insurance, would pay the remaining 25% or 50% of the daily cost of care. The Colonnade and the Pillar and the Canopy plans pay in home, in assisted living, and in nursing care. But for those who truly want to stay in their home and they intend to stay in their homes for the rest of their lives, we do offer a plan called the Foundation. We will pay up to $131 per day for care for a member in their home, as long as that home is not a licensed assisted living, a licensed memory support, or a licensed nursing care. That could be with your child, that could be anywhere else. If someone wants to join as a member, there is no maximum age, but each person must be at least 55 years old. There is an application and a financial statement you would complete. And then initially, someone must live in Northern Virginia or Washington, D.C. Probably the most important part of the Goodwin Living at Home is that this is a plan for those who are looking ahead, because there is a medical review. We request 2 years worth of medical information for anyone who is applying. Then we do a home assessment, which is the actual home itself. There's a cognitive assessment, and there's also a functional assessment. So members, that information with our facilitators who do the assessments and the medical reports go to our physician, our medical director, who gives us a recommendation whether someone is medically approved or not. Because this is an option for those who pre-plan, the earlier you do it, the more likely you are to be able to join. Again, Goodwin Living at Home is designed to be the option for someone who plans to stay in their home. It will protect your assets against the rising cost of care because we're prepaying for the future cost. And it removes the necessity for others to look for care for you and the burden of caregiving from them. If you have any other questions, my name is Shannon Bishop, Senior Sales Consultant, and my contact information is on the screen.
I wanted to thank you very much, to tell you that I'm very happy you kept the 10 minutes. And now we are going to hear from Jessica Ford for the first time in our presentation.
Yeah, I'm so excited to be here. Shannon, thank you so much. And to all the presenters, thank you so much for all of your valuable information today. Elena, thank you for inviting me. I'm going to go ahead and share my screen. All right, there we go. Okay, so hi, I'm Jessica Ford. I am the Director of Client Relations here at Capital Caring Health. Capital Caring Health is celebrating its 45th year here serving the community in the DC metro area. And we're a nonprofit, and I've been here for just over 11 years. So today I'm going to be talking to you a bit about hospice and palliative care. So I'm going to go ahead and start showing my slides. So first, I definitely want to talk about advanced illness care, which is the umbrella under which both palliative care and hospice care fall. One of the most common questions I get, what's the difference between the two? How are they similar? How do they differ? So first, I'd like to talk about how they are similar. And there we go. They are both very similar, or their similarity starts because they both focus on managing symptoms to enhance quality of life during a critical illness. So here's where they're going to differ. Hospice is utilized when psychological, spiritual, emotional, and social aspects of advanced illness decision-making change from medical treatments meant to cure to focusing on comfort and support. So I wanted to highlight that part. It's really, that's what's going to be your biggest differentiator between palliative and hospice care. Hospice care is used when a patient's physician determines the prognosis for that illness is 6 months or less. Palliative care can be delivered concurrently with other medical treatment focused on cure and has no specific time limitations. So again, the biggest difference between these two, palliative care, you could receive that care simultaneously as receiving medical treatments that are focused on cure. Hospice is perfect for when a patient is ready to discontinue those medical treatments, focusing on curing the illness, and are now more focused on comfort and support. So who's eligible for hospice care? Hopefully many of you know that hospice is a Medicare benefit. And so just the three kind of top points to hit on here is a patient who has Medicare Part A, a patient who elects the hospice benefit by completing the necessary paperwork, and by getting a certification from both the attending physician and a hospice physician certifying a prognosis of 6 months or less if the terminal illness runs its normal course, would be eligible for hospice care. Really, really important to point out the bullet point there, because while Medicare does have a wonderful benefit for hospice, hospice is also covered under Medicaid and most commercial insurance policies. When is it the right time for hospice? It's really important to note that hospice should and can be considered for anyone, regardless of age, here at Capital Caring Health, who is in the advanced stages of a progressive illness. And I want to just stress anyone, regardless of age. We unfortunately have a PEDS program here at Capital. We care for children as young as a day old, all the way up to 110. And so wanted to list some of the most common illnesses that we see and that our patients or that our clinicians care for here, including cancer, dementia, heart disease, lung disease, kidney failure, and neurological conditions such as Parkinson's and stroke. And a patient can be in hospice for up to 6 months, and honestly, even longer, depending on the individual circumstances. We have patients who've been in our care for a year and a half, 2 years. So really wanted to stress that. I think it's kind of an old way of thinking. People's kind of think of hospice as like those last couple of days. And in fact, as you can see there at the end of the slide, really to receive the greatest benefit, a patient should really think about electing services and trying, and spending some time in our care, 2 to 3 months. We've really found in feedback from our patients that they really wish our families, that they wish that they reached out to us sooner. They just seem to be a lot more satisfied the longer that we're able to be involved and provide that important support. So once a patient and their family elect hospice care, this is what the team looks like. And I also want to stress that we absolutely individualize a patient's plan of care. Really want to talk to them about what their goals are, what their quality of life means. So they don't have to invite every one of these people into their home or into their plan of care. But typically what this looks like would be a registered nurse case manager would really be managing the patient's care. Also included in that team, very important role would certainly be the social worker. Also, we have hospice aides that would come a few times a week and assist with those activities of daily living. So assist with, taking a bath or shower and at mealtime. There are also counseling services that are covered under the hospice benefit, including a non-denominational chaplain, dietary counselors, and then certainly our bereavement counselors, which follow the families for up to 13 months after the patient's passing. This is all overseen by a hospice medical director. And it's also important to point out that there are some other really important roles that are part of our hospice team, comprise the hospice team, which include physical therapists, occupational therapists, and speech therapists. And those therapies would have to be referred or recommended by and approved by our nurse case manager, and approved by the hospice benefit, like the Medicare hospice benefit. Volunteers are an enormous part of our care team, and really can do quite a bit of things, including everything from sitting and maybe giving the caregiver a little bit of a break, and maybe sitting watching TV, reading a book, enjoying the sunshine, taking a walk, to maybe some light house cleaning. So that is your care team. Also included in the hospice benefit are some additional things, so including durable medical equipment. That could mean a hospital bed, a wheelchair, a bedside commode. Medications related to the terminal diagnosis are also covered under the hospice benefit, as well as medical supplies like briefs and pull-ups. I'm going to talk to you quickly about the 4 levels of care that you'll see in hospice, more on the next few slides. But just quickly: routine, continuous, general inpatient level, and respite. So going into this is where the majority of our patients fall, would be in routine home care level of hospice. And this care occurs wherever the patient calls home. Some of the most common places that we see people would be like a nursing home or their own home apartment. But we absolutely have patients in homeless shelters, in jails, and motels and hotels. We really go wherever the patient calls home. And this may be contrary to what you see in a lot of movies where they say, my loved one has gone to the hospice. So I just wanted to point out that it's not a place, it's a service, and we really will go wherever is home. So then on to level 2 and 3 of the hospice levels of care. Level 2 is called crisis care here at Capital Caring Health. This is a short-term type of level of care, and it allows the patient to remain in the home. And really the goal of crisis care is to have an LPN or an RN assist with managing complex symptoms and potentially provide additional training to the family in order to get those symptoms managed properly. If we're not able to manage the symptoms in the home, or they're just too much for a home setting, then we would be looking at the 3rd level of care, which is general inpatient level of care, or GIP. It's also typically a short-term type, level of care. However, this is provided in a hospice-owned facility. It could be also in a contracted hospital, so a hospital we've contracted with. It could also be provided in a Medicare certified skilled nursing facility that we've contracted with. Capital Caring Health is unique in this area in that we have 2 inpatient centers. One is the Adler Center for Caring in Aldie, Virginia, as well as the Johns Hopkins Sibley Memorial Hospital in DC. And again, the goal of this general inpatient level of care, or GIP, is to get those pain or other symptoms managed and under control when we weren't able to do that feasibly in a different setting. And then with the goal of returning them back to wherever home is. Finally, the last level of care that is covered under the Medicare hospice benefit is respite care. And this is actually a level of care for our caregivers, for our families. This is, again, a short-term type of a situation. It's limited to 5 consecutive days, but the goal is to really just give that caregiver a little bit of a break, a little bit of relief. We really understand how challenging this time can be. So it's really a wonderful, wonderful benefit. And what happens is, we would move your loved one to potentially our inpatient center in Aldie, Virginia, perhaps at Sibley, and provide you a little bit of a respite, a break there. We'll take care of your loved one. You take a breather. We also have contracts at many of our nursing homes in the area and could do respite there as well. Unfortunately, we can't partner with our assisted living facilities when it comes to respite. And that really has to do with the Medicare hospice benefit, in that there's quite a bit of nursing oversight that's required in order to be within the guidelines. So what is it covered under hospice? First and foremost, treatment intended to cure or modify the terminal illness, right? We really talked about that in the beginning, where hospice is appropriate when a patient is ready to kind of move away from the curative treatments and really focus on comfort and quality of life. What is also not covered under hospice would be care outside of the hospice plan of care. And so this one I definitely get this question a lot, and I wanted to make sure I pointed it out. That doesn't mean that you can't go see a podiatrist, see an ophthalmologist, go to the dentist. You've got a sinus infection and you'd like to see the doctor. Absolutely, you can still do this. It's just not covered under that hospice benefit. So absolutely, you can still continue to see those specialists. What is also not covered would be room and board in a nursing home, as well as care from another provider that's duplicate care to what the hospice is providing. So now we've talked a little bit about hospice. I wanted to circle back to palliative care and talk a little bit about what that is. So services under palliative care would begin by developing an individualized plan of care. This often, definitely includes identifying one's goals for treatment, right? So this is for somebody, again, who is pursuing curative treatments and would like some additional support there, expert symptom management, that would be provided by our palliative care nurse practitioners, as well as providing some assistance in advanced care planning. So people that are pursuing curative treatments, a lot of times will find that there are some side effects that go along with those. And that's where a palliative care nurse practitioner could be a great help to you in palliating those symptoms of the curative treatment. So at Capital Caring Health, our nurse practitioners are specifically trained in advanced illness care. They're going to work to collaborate with the patient's primary medical team to address the needs of the patient and the family. And we're going to have some discussions regarding the disease's progression, treatment options, what's out there, weighing those out with you, and making recommendations to other community resources. Palliative care can be. Jessica,
oh, sorry. Please try to wrap up.
Okay, you got it. I think I'm maybe one slide, two slides away.
To have the question session.
Okay, you got it. So palliative can be delivered pretty much anywhere, as it says below. Anyone is eligible for palliative regardless of age, as long as they have a life-limiting illness. And these services are covered under Medicare Part B, some Medicaid programs, and many commercial health program or plans. So anyone is welcome to contact us for a free evaluation. If you're not sure which service, give us a shout. Here's our contact information below, including my direct contact information if you'd like to, ask me some specific questions. Thank you so much for your time, and I'm turning it back over.
Thank you very much.